strategies after resistance. And here I'm only presenting one abstract, although I will say that there's similar data for several additional second-generation ALK inhibitors. This data was presented by Alice Shaw, and this is looking at the clinical activity of LDK-378. And again, there are several similar drugs in the clinic that are being evaluated in the context of clinical trials. I won't spend a lot of time on this slide, a background on ALK. In many respects, I feel that the science in ALK gene rearrangements is not as well understood as we would like. ALK gene rearrangements probably are really seen in about 3 to 4% of all non-small cell lung cancer cases. Acquired resistance, unfortunately, remains a very vexing problem in all of our targeted therapies. ALK gene rearrangements are no different. We have had less time to study ALK gene rearranged tumors at the time of progression than we have EGFR mutant tumors at the time of progression. But what you can see is that there are some cases where the ALK gene is amplified. That means there are more copies of the ALK gene that are seen. There is also a portion of cases where an additional mutation will be seen in the ALK gene. Now, just as an amplification is more copies of the ALK gene, a mutation is an abnormality in the ALK gene. As you can see in the gray portion of this schema, you have bypass tracks, and in many respects, a lot of those end up being truly unknown exactly why a person stops responding to crizotinib or Xalkori. Xalkori is the trade name for crizotinib. LDK-378 is a very potent ALK inhibitor, and as I say, there are many other drugs in the clinic, and one of the reasons is that there are many drugs that look much better in the laboratory as an ALK inhibitor than Xalkori or crizotinib, which is over on the right. The IC50, which we show here, just is how much drug it takes in the laboratory to inhibit half of the growth of cancer cells. As you can see, it takes a lot less drug of LDK than it does of crizotinib, and a similar thing is seen on the right in animal experiments. And as I say, many different companies have similar data, and part of the reason is that crizotinib or Xalkori was originally looked at as an inhibitor of a similar protein called MET, M-E-T, and in fact that is still being evaluated. But there are now several specific ALK inhibitors, including LDK-378, that are trying to improve on the results. The study design I will gloss over just to say that they were looking to escalate the dose, and they were looking at both patients who did have prior crizotinib or Xalkori and patients who had not had prior Xalkori. The interesting thing here, and unfortunately I'm looking and I see that the key has yellow and yellow, which is not a particularly helpful way of looking at it, but in the end it doesn't matter because the response rate really tended to be almost identical in patients who had received prior crizotinib or Xalkori as patients who did not. That is very exciting, particularly for those of us who have been treating EGFR mutant lung cancer for a long period of time, because in EGFR mutant lung cancer, we do have several second-generation EGFR inhibitors. Unfortunately, we have not been very successful at getting a high response rate in patients who progress on Tarceva, for instance, with a second-generation EGFR inhibitor. But with this drug and with some of the similar compounds, you are seeing results in people who have previously been treated with a similar drug. One significant advantage of LDK, and this I believe is seen in some of the other second-generation ALK inhibitors, is that responses can be seen in the brain. The brain is a particularly problematic place for lung cancer in general, and ALK gene-rearranged lung cancer is certainly a disease where brain metastases are a significant problem. In this schema, you're looking actually at a CT scan of the brain. On the left is the baseline, and they have arrows pointing out, and you can see that there's significant shrinking of brain metastases. The other thing is that patients did well for many months. As with anything, this is a significant range, but it is not a situation where patients, for instance, would have a brief reduction in their tumor volume and then the disease would grow back. So I think that this was a very exciting set of data, and again, it is one of several different compounds that are quite similar.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support.